Okay. Good morning, everyone. Len is away this week. Our presenter today is going to be Dr. Gabe Mendoza, one of our first-year fellows, and he will give us presentation about health inequities in allergy and immunology. Gabe, are you able to share your slides?
Yeah, sorry. I think they should be shared now. Do you see them?
I do.
Okay.
Hopefully, does everybody else see them okay?
Good.
Okay, awesome. Okay, Gabe, take it away.
Great. Thank you, Anya. And hopefully everyone can hear me. So yeah, a second year fellow. And like Anya said, I'm going to present on health inequities and allergy immunology with focus on food allergy because the topic of health inequities and allergy immunology is so large. So we'll just focus on food allergy today and then connect to my QA project that I'm doing with along with Kelly this year. So disclosures, I have no disclosures. Word of the day is equity. So before I start, I just want you all to get to know me a little bit better. And since we're talking about health inequities, I think it's important just to kind of know why that topic is important to me. And I'll go through that a little bit through the slide. So I grew up in a Mexican-American household. This is my family I grew up with a lot with my grandparents and cousins. My parents immigrated from Mexico, in the Mexico City area. So these are my parents here. I grew up in Orange County initially and then moved to Long Beach, which is about half an hour south of LA. I grew up a Laker fan. And then this is me in Long Beach here, had some pets. And then I went to college at UCLA, and these are just some of the folks that, some of the friends that were there. I was part of like a Latino organization there, and these are some of the folks that I worked with. After college, I did a program called City Year. I was actually tutoring students in Watts, which is in South LA, ninth grade students. So that's what's represented here. And then I went to med school at UCLA, part of the Charles True program. While I was in med school, I did go to Mozambique. I was able to see some, take care of children abroad and see some of the inequities that are seen in a global scale. And then matched Seattle Children's. These are some of my co-residents. And specifically, these are some of the co-residents that I helped start the health equity rounds at Seattle Children's. That's one reason why I have this template for Seattle Children's for this PowerPoint, because that's where I learned a lot of the information I know in terms of health inequities. And I've been married in residency. This is my wife. She met at UW as internal medicine resident. Yeah, this is a NERF, Network of Representative Residence Fellows. I'm going to talk a little bit more about that in the next slide. This is Hispanic Heritage Month event we had. These are some of my co-fellows I'm with from last year, Stacy and Sana, and then Jocelyn, Christine, and then I was just in Alaska last month and was able to see take care of a lot of native population, the native population there, which we don't have a lot of data for, unfortunately. So yet another inequity that's present. And just wanted to do a plug for the Network of Representative Resident Fellows. I was the president of this organization last year. We hosted a lot of events, mentioned Hispanic Heritage Month, Native American Heritage Month, Black History Month, Asian American and Pacific Islander Heritage Month, and we reached out to the houseless population and built little homes for them. So if people are interested in learning more about that organization, I'd be happy to connect them. All right, so first, I'm going to start with the land acknowledgement. So I want to acknowledge that we are in traditional land of the Coast Salish people, including Squamish, Tuwaalip, Duwamish, and Muckleshoot nations, the first people of Seattle, past and present. This is actually Chief Seattle, which is what who the city is named after. This is in 1864. We express our gratitude for this land itself and honor the ancient heritage of the Coast Salish people who continue to be with us today. I also want to acknowledge that this country would not exist or prosper if not for the labor of enslaved Black people. Sorry, this cut out here, but this is adapted from the Health Equity Rounds at Seattle Children. So we honor the legacy of the African diaspora and Black life knowledge and skills stolen due to violence and systemic oppression. So learning objective number one, first is start build a good foundation for everyone. So recognizing the root causes of health inequities in allergy immunology and in general in our society. So there's actually a work group report in health disparities and health inequities by the Quad AI. So I encourage everyone to check that out. This is from that work report. So health equity, I think a lot of people have seen similar images. I actually like this image a little bit more. And that is from Dr. I actually don't know exactly how to pronounce her last name, but Luisia's. It was a talk that she gave at the Quad AI back in 2022. And inequality is unequal access to opportunities. Equality is when both people have the same support to have access to resources. But in this slide, you can see even though the ladders are the same height, this person is not able to access the fruit. So equity would be to actually provide the support that each person needs to have the same resources. But the true goal is justice. So not, you can see the tree is leaning to one side. So actually fixing the root cause of the problem, so that you can have similar resources provide similar support, provide similar resources to people. Terminology. So based on the CDC, this is the definition of health disparities and health inequities. So there's a difference. So disparities are differences in the burden of disease, injury, and violence, or in opportunities to achieve optimal health experienced by socially disadvantaged racial, ethnic, and other populations, groups, and communities. And then health inequities are listed here. So not just the disparities that are present, but the differences that are underlying that. So in health status or in distribution of health resources, as an example, arising from social conditions in which people are born, grow, live, and work, and age. Health inequities are unfair and could be reduced by the right mix of government policies by the WHO, that definition. So another slide taken from my time with health equity rounds at Seattle Children. So this is a definition of what we call structural racism, which is one of the inherent causes of health inequities. So you can see the definition listed there that is quoted from health equity rounds. And part of that has to do with implicit bias, which is something that we all carry. And there's a lot of different factors that lead to this. So we see in the media, what we see that can cause us to have implicit bias towards certain people. History, policies, practices have over time caused there to be a structural disparity present, and then inequitable outcomes and racial disparities are the consequences. So this is in terms of an allergy immunology framework. Taking it one step at a time because I know there's a lot going on. So determinants of health are listed here. One that I'll kind of focus on throughout this is racism. Upstream pathways of structural racism include residential segregation, which happened in Seattle, for example, with redlining certain parts of Seattle where people of color could live and they couldn't live in certain other parts of the city, which have led to some disparities. This physical environment, so there's different pollutants in the air, depending on where you live, and housing quality, which I think we as allergists know. There's increased incidence, for example, cockroach and rodent allergy in a lot of inner city communities. And that can lead to biologic differences caused by environmental factors. So a lot of times from physiologic stress responses that are chronic, which can lead to some of the racial disparities that we see in the field. And this figure kind of talks about that as well, but it kind of highlights kind of different things that to think about that lead to health disparities. So thinking about how structural racism can physiologically alter immune function, you can see here one thing I want to highlight is ambient air pollution. So particulate matter 2.5, nitric oxide, diesel, these things can alter the airway microenvironment, for example, like in asthma. It can cause a difference, an imbalance in TH1 and TH2 and TH17 activity, which can lead to differences in the microbiome, can also cause epigenetic modifications. And this could also be stimulated by the stress response. So I'm not going to focus on asthma for this talk. Maybe at the end of the year when I talk about my research, we'll get to that. But I did want to talk about this one slide. This was image courtesy of one of my mentors in residency, Jim Stout, who's done a lot of work in asthma with the Healthy Homes Project. So I like this slide because it shows that there's increased incidence of asthma-related hospitalizations and ED visits among Medicaid children living near the I-5 highway. So this goes back to this slide where ambient air pollution, such as diesel from cars and trucks, can cause significant differences in outcomes in terms of asthma. And so this one really hits home for us here in Seattle. And then, so in general, like I mentioned, all these diseases in our field have disparities. And it'd be a lot to talk about for one talk. So today I'm going to focus on food allergy. So in terms of the conceptual model for health disparities research, first generation research would be documenting the existence of health disparities, so just knowing that they're present. Second generation is explaining the reasons behind those disparities. Third generation, providing solutions to eliminate those health disparities. So for food allergy, we're mostly kind of here in the first, second generation still in terms of research for detecting the health disparities and understanding them. For asthma, we're starting to get more into third and generation, fourth generation. But for food allergy, we still got room to grow in. So the next learning objective would be understanding epidemiology and health disparities related to food allergies. So the food allergy epidemic on this slide summarizes some of the data from the data that Ruchi Gupta has obtained over the years. So based on a national sample of parent proxy reported data, 38,406 children and 40,443 adults. We can see some of the statistics here. So 1 in 10 adults have food allergy, 1 in 13 children have food allergy. I'll be focusing mostly on children today. So these are the big 9 that we know about. So thinking about the food allergy in terms of specific food groups, you can see them listed here. You see that peanut and milk are the most common food allergens in children. In terms of overall physician diagnosed food allergy prevalence is 4.7%. And if you just based on the data from Ruchi Gupta, the screener that she used, even if for patients that weren't seen by a physician, there's convincing food allergy prevalence would be about 7.6% in overall. Looking at disparities within specific foods, we have peanut, tree nut, milk, egg, finfish. As you can see here, they all have statistically significant differences between white non-Hispanic, Black non-Hispanic, Asian non-Hispanic, and Hispanic. Looking more closely, Black children seem to have the highest incidence of peanut, shellfish, and finfish allergy. Asian children have the highest incidence of tree nut allergy, and Hispanic children kind of, in general, kind of lie in between, it seems like. But in general, have more food allergy for these specific groups compared to, like I mentioned, white children. Looking at prospective cohort study of 100 children, Black children were found to have higher odds of wheat, soy, corn, fish, and shellfish allergy. Hispanic children have higher odds of corn, fish, and shellfish allergy. Looking at birth cohort study of 590 individuals at 3 years of age, those that had self-reported Black race were found to have sensitization to multiple foods based on skin prick testing and serum IG testing. And prevalence of peanut IG, specifically, was greater than 95%, found, I think, statistically significant, and was 3 times more likely in Black children than non-Black children. Food allergy disparities in terms of anaphylaxis and ED visits. So in a sample of 831 children, you can see here that percent of food-induced anaphylaxis is higher in Black, non-Hispanic, and in Hispanic children. And then you can see some of the other issues here: eczema, allergic rhinitis, asthma. And then this is still based on the previous slide. So Black and Hispanic children have higher incidence of food-induced anaphylaxis and ED visits. I have a couple of studies here to maybe answer why might this be. So it's less likely that these patients are provided anaphylaxis action plans based on this study here. These patients are also less likely to have available epinephrine autoinjectors at home or at school, and less likely to be seen by a specialist. Looking specifically at schools, so epinephrine has been shown to be less available in schools when needed in low-income children. This is using National School Lunch Program as a proxy for being low income. So you can see here as percentage of low-income students associated with no epinephrine injector prescription. Most of those that have lower schools that have lower percentage of children that are in the National School Lunch Program, they have a much higher percentage of having epinephrine or a lot more epinephrine injectors available at school. So there's a lot of schools in this in our nation that don't have any EpiPens available. And then looking at limited English proficiency as another disparity. So children with limited English proficiency also have less access to epinephrine injectors. There's also a disparity found in rural schools. So you can see here, rural schools, they have more severe reactions where epinephrine was not available. Now switching to the economic impact of food allergies. So the overall economic cost, $24.8 billion. Direct medical costs are $4.3 billion. Family costs, $20.5 billion, which is about $4,184 per year per allergic child. So this study is looking at demographic characteristics. Over here, it shows demographic characteristics of children with food allergy. In general, this study was looking at socioeconomic disparities of childhood food allergy. So something of note here is looking at household income. There is increased percentage of children with food allergy in households with lower household income, so less than 50,000 compared to those with higher household income, greater than 100,000. Looking more closely at this data, we have this table here. This is in mean annual costs in dollars. And the standard error is listed in parentheses. So you can see here, actually for white families, there's a lot higher costs in general. So that in general initially might be deceiving. But when you look at it more closely, you see that the costs are with special foods, more costs for medications, out-of-pocket specialists. And then for ED visits, there's actually much less cost, for example, compared to Asian family households, which spend a lot more on ED and hospitalizations compared to white families. And kind of similar trend with the African-American and Hispanic as well. So looking here at a summary of that data. So non-white families spend less on specialty visits, so seeing specialists less, allergists less. They spend less out of pocket for medication, so they have less. They have less epinephrine available, epinephrine autoinjectors, and they have less access to foods that are allergen safe. And as I mentioned about Asian families, disparity with ED visits and hospitalizations related to food allergy. This is once again looking at looking at more social economic factors. So once again, those are households with less than 50,000 household income. You can see the disparity in terms of they spend more for ED and hospitalizations and less for specialists compared to those with higher incomes. Also less for special foods. So that summary of those findings are listed once again here. So for the rest of the talk, I'm actually going to focus on this point, spending less. So why are these low-income families spending less on allergen-free foods, and what's the impact of that? What kind of disparities might we see further from that? So as you can imagine, kind of walking in a grocery store, and there's so many different foods, and looking at all the, you have to look at all the food labels. If you have a child with food allergy, it could really be stressful and difficult to really find foods that don't include, for example, peanut or sesame, if your child is allergic to those foods. And typically, for example, even if you go to a food pantry, a lot of these food pantries may not have allergen fruit safe food. So there's a larger portion of those foods that are going to be less available for patients that have food insecurity. So I'm going to talk about food insecurity for a large portion of this talk because it really ties to this issue of health disparities between patients with food allergies. So just overall food insecurity, 1 in 7 children live in households with food insecurity. You can see here some of the negative impacts of that are poor health status, poor development, mental health problems, poor educational outcomes. And in the family, there's, like I mentioned, more food anxiety. There's decreased availability of the foods that the family is able to eat, decreased nutritional quality, and sometimes inadequate food intake. There's some food resources here, which I will talk more about later on. So here, looking at the trend of food insecurity, fortunately, there has been a decrease overall in the prevalence of food insecurity in children. But as you can see, the level of food insecurity is still much higher in Black, non-Hispanic, and Hispanic children compared to white children. So you can see here, kind of most recently, 2019, it's about 25% for Black children had food insecurity. Hispanic children about a little bit more than 15%, and for white children about 10%. So there's actually increased prevalence of food insecurity in patients with food allergy, and that's not just a coincidence. So looking at this recent study, what's called the Forward study, there's found to be specifically increased food insecurity in Black children with food allergy and overall increased incidence of food insecurity in households with children with food allergy, which, as I mentioned, would increase the burden of meeting basic nutritional needs for these children. And even when adjusting for income and education, caregivers of Black children were more likely to report lower food security and difficulty affording medication compared to caregivers of white children. So this is from the Food Equality Initiative, which is actually in Kansas. It's a great story. Actually, there's a mother of a child with food allergy in Kansas who had a really hard time finding allergy-safe foods. They had food insecurity, and there weren't really any food pantries available that specifically catered to patients with food allergy. So actually, she just started her own organization to help with that problem. It's called the Food Equality Initiative. And since then, there's been other similar food pantries that have started up across the country. None that I could find in Washington State, but mostly in the East Coast, like Pennsylvania, Massachusetts. And as you can see here, one reason why this is such a big deal is also the cost. So if someone is allergic, for example, to cow's milk, almond milk is so much more expensive generally than cow's milk. Same thing with these other alternatives: rice milk, soy milk, flax milk. If someone's wheat allergic, gluten-free spaghetti is more allergic than typical spaghetti. With egg, same thing. It's also more expensive. Gluten-free options and egg-free options compared to those with egg. Peanut butter also, for example, sunflower seed spread are much more expensive than peanut butter. And so on. So you can see there's really a big financial burden for food allergic patients. And looking more closely at this study, so this study looked at 650 children. Actually, I should say 650 children with food allergy and 650 children without food allergy. Specifically looking at egg allergy, it was found to have in Black patients with egg allergy, there was an increased incidence of food insecurity, is what this study highlighted here, and that's what I highlighted in this box. It was only statistically significant finding that was found for this study. And also, I should say, milk and egg allergy, which is why I highlighted that in the photo here. So connecting the dots. So why is food insecurity important to think about as an allergist? Well, these patients in general with food allergies are, like I mentioned, are greater risk for food insecurity, which can exacerbate the problem. I didn't get into it in this talk just because of time, but there's delayed introduction of foods in general for patients with food allergy, which will increase the risk of developing additional food allergies, which increase the risk of accidental allergen exposure, which increases the risk of ED visits and hospitalizations. And I mentioned the decreased access to allergy-safe foods, which also leads to, likely leads to this issue. So now moving on to the last learning objective. So identifying possible interventions to address health inequities in families with food allergy. So interventions to consider. So epinephrine, like I mentioned, epinephrine autoinjectors are less prescribed for patients who are Black, Hispanic. There's limited data in Native American families, but also in those families. So we should think about prescribing and be intentional with prescribing epinephrine autoinjectors to our patients with food allergy, especially from those backgrounds. There's an increased risk for food insecurity. And like I mentioned, in our patients with food allergy, especially in our Black patients. So this should be addressed with our visits with patients. And food allergy education should occur in partnership with primary care clinicians and advocacy groups, particularly in high-risk communities. And these groups probably have more time perhaps than we do. So it's kind of our job, though, to kind of help educate these groups and partner with them to help our patients. So I know we all give our patients anaphylaxis action plans in general, but as I mentioned before, we might be giving them less to our patients from these these groups that have increased disparities, as the literature has implied. This might be from implicit bias. So just being really intentional about giving anaphylaxis action plans to our patients. And thinking about language, like I mentioned, patients with limited English proficiency seem to have less access to epinephrine autoinjectors, and they also tend to have less times an anaphylaxis action plan given to them in the language that they prefer. So as an easy resource to access, just know that FAIR, the Food Allergy Research and Education organization, has access to a anaphylaxis action plan that's already translated in Spanish that is easy to access. So you can just go to the website and download it. So the Quality Eye also thinks that food insecurity is important. So and they had a work group report on this, and the rest of the presentation, I'm going to kind of focus on that. So our allergist screening for food insecurity, as you might guess, not really. So in this figure, it shows when they asked allergists, do you know if any of your patients have faced food insecurity in the past 6 months? Only 28.8% of the allergists said yes. The grand majority said that no, that they didn't know if the patients had faced food insecurity in the past 6 months. A toolkit that would be one that's really readily available and that I have found helpful as I was reading through it is this from the AAP, the American Academy of Pediatrics, in partnership with the Food Research and Action Center. You can look it up at the website listed here. Within this toolkit, you'll find what's called the Hunger Vital Sign. So really easy food insecurity screener, 2 questions that's been validated. It was validated back in 2010 for children. Actually, since then in 2017, it was also validated for use among adults. So the questions are, within the past 12 months, we worried whether our food would run out before we got money to buy more. And then the second question, within the past 12 months, the food we bought just didn't last and we didn't have money to get more. So really easy questionnaire to fill out. And this has really high sensitivity for detecting food insecurity in our patients, greater than 99%. So this is actually the model that I'm using along with my co-fellow, Dr. Kelly Collis, and our mentor, Dr. Jenny Sun, who is helping us start a food insecurity screener at UW-Roosevelt. We're hoping to start this next month. We're going to provide a questionnaire at check-in at the pediatric allergy clinic that we have there, collaborating with a clinic social worker to connect patients to food resources, and also having a list of free food resources available in the area. And hopefully in the future, this could be expanded to other sites. So as you can see here, this is kind of the phase we've been in right now, kind of preparing. We're going to educate and train staff on and thinking about food insecurity. It'd be mainly, like I said, it'd be done in check-in. So we'll be coming mainly the staff doing this. And as best as we can, we'll kind of follow the AAP recommendations that are listed. And then after the screener is done, it's important to intervene, as I mentioned, connecting patients to resources and documenting, tracking in the medical records, advocating and educating to help address the root causes of the food insecurity would be another step that would be great to take on. As I mentioned, it's important to think about the language that is preferred for our patients. So there's one readily available for Spanish that we'll be using during our QI project. There's also other translations available, which we won't have on our sheet that our questionnaire that patients will fill out, but if needed, we'll have access to online. There's already 11 languages that have been translated by the Hunger Vital Sign group, and for example, Russian is listed here. In terms of resources, we'll connect patients to. I mentioned kind of national resources. FAIR has lots of food banks and soup kitchens. Like I mentioned, nationwide, some of them cater to food allergy patients. Unfortunately, there's not, I haven't found any in Washington State that do that. But there are other food resources available, though, that are local. So really close to the Roosevelt Clinic is the University District Food Bank, which we could connect patients to. And Seattle Children's also has a food pantry that they have on Tuesday, Wednesday, Thursday, and Friday at these hours. So families can just stop by at those times. It's on the 7th floor near the cafeteria on the ocean side. And to have access or to allow help families find other resources, there's this tool called Washington 211. So you just dial 211 and you have access to voice-operated resources that that you could find, including food pantries, and there's also a website that goes along with it. So I talked about how to kind of think about at the larger level and the kind of the justice level and helping fight the root causes of these food insecurity, which is a health inequity. You think about providing access to appropriate and safe meals through the public health school system. That might be something that could be done, accommodating needs of food allergic households and food banks and pantries. Like I mentioned, in Kansas, the food equity initiative has started that there. Maybe someone can start that here in Washington State. That I'd be interested in helping team up with community workers on that. Reducing restrictions on WIC, allowing foods to ensure safe brands. So currently WIC doesn't provide some of these allergy safe foods. For example, they may only provide financial help for cow's milk products or peanut products, and not so much, for example, sunflower, butter, or almond milk, for example. And then another policy change that could occur that would help would be adjusting the emergency food assistance program policies to ensure there are commodities free of the common allergens. So these policy changes can help food allergic households with food insecurity. And ultimately, it would be great if health insurance can help pay for the prescription for these allergen-free foods that I mentioned are really expensive currently. And this is all out of pocket for our food allergic families. So once again, we're today. So actually, I ended a lot earlier than I thought I would. I guess I sped through some of these slides, but it's a lot of time for questions if folks have questions on any of the topics that I mentioned today.
Great talk, Gabe. I have seen prescriptions for like vegetables and fruits or produce. That was when I was living in New Orleans. Tulane has this like test kitchen that does a lot of culinary medicine. So I think that'd be really interesting if they were able to do prescriptions for the allergen-free foods.
That's awesome, Jocelyn. Yeah, I didn't know New Orleans had a program like that. Yeah, I think that if something like that, Washington State could happen, that would be, I feel like, a huge help. All right, I'm not seeing any questions in the chats. So let's see.
Great job, Gabe. Thank you. I guess if there are no questions, we can end a little bit early today. Thank you very much for talking to us on this important topic, Gabe.
Of course. So I'm just going back to see if there's, in case people had questions on other things, on other slides here. So yeah, like I mentioned, yeah, today I focused on food allergy, but in the future, I'm hoping to, at the end of the year, maybe talk more about asthma as well, plugging it into my research project. But yeah, so for now, yeah, I think we could end the talk. And yeah, if anyone has questions, don't hesitate to reach out. I'm happy to help out with this.